Metformin, the first-line oral anti-diabetic drug for type 2 diabetes mellitus, a biguanide that works without stimulating insulin secretion. Mechanism of action. The most important action of metformin is that it reduces gluconeogenesis in the liver, which is the primary mechanism responsible for its glucose-lowering effect. Since excessive hepatic glucose output contributes significantly to fasting hyperglycemia, reducing gluconeogenesis helps lower blood glucose levels effectively. The second action is that metformin improves insulin sensitivity. It enhances the action of insulin in skeletal muscle and adipose tissue, allowing these tissues to respond better to the available insulin. As insulin sensitivity improves, there is increased peripheral glucose uptake, meaning more glucose is taken up and utilized by peripheral tissues, particularly skeletal muscle. Finally, metformin also reduces gut absorption of glucose, lowering the amount of glucose absorbed from the intestine after meals and helping control postprandial blood glucose levels. No hypoglycemia risk. An important advantage of metformin is its no hypoglycemia risk profile. Unlike drugs such as sulfonylureas, metformin does not stimulate insulin secretion from pancreatic beta cells. This point is clinically very important. Since metformin does not force the pancreas to release additional insulin, it does not usually cause blood glucose to fall below normal levels. Instead, it lowers glucose primarily by reducing hepatic glucose production and improving insulin sensitivity. Because metformin works independently of insulin release, the risk of hypoglycemia is low when it is used alone. This makes it safer for many patients and is considered a major advantage over several other anti-diabetic agents. Adverse effects. The most common adverse effects are gastrointestinal symptoms, including nausea, vomiting, diarrhea, and abdominal discomfort. These symptoms are usually mild, occur early in therapy, and can often be minimized by taking metformin with meals or gradually increasing the dose. Some patients also complain of a characteristic metallic taste in the mouth. With long-term use, metformin may cause vitamin B12 deficiency. Therefore, periodic monitoring should be considered, especially in patients who develop anemia or peripheral neuropathy. A rare but serious complication is lactic acidosis. Although uncommon, the risk increases in patients with renal failure, severe hypoxia, or liver disease, where lactate clearance is impaired. Clinical uses. The most important indication is type 2 diabetes. Metformin is considered the first-line drug, particularly in overweight or obese patients, because it improves insulin sensitivity, does not cause weight gain, and carries a very low risk of hypoglycemia. Another important use is in prediabetes. In high-risk individuals, metformin can help delay progression to diabetes, especially when combined with lifestyle modification. Metformin is also widely used in polycystic ovary syndrome. By improving insulin resistance, it helps restore ovulation and may improve menstrual regularity and fertility. Finally, in metabolic syndrome, metformin improves both glycemic control and overall insulin sensitivity, addressing a key underlying abnormality of the syndrome. First line in overweight patients. An important clinical application of metformin is its role as the preferred first-line agent in type 2 diabetes mellitus, particularly in overweight or obese patients. Why is metformin preferred in this group? First, it effectively lowers blood glucose by reducing hepatic glucose production and improving insulin sensitivity. Second, unlike some anti-diabetic drugs, metformin is generally weight neutral and may even produce modest weight reduction, which is beneficial in patients who are already overweight. Another major advantage is its low hypoglycemia risk. Because metformin does not stimulate insulin secretion, hypoglycemic episodes are uncommon when it is used alone. These characteristics, effective glucose control, a favorable effect on body weight, and a low risk of hypoglycemia, make metformin the treatment of choice for most newly diagnosed overweight or obese patients with type 2 diabetes. Metformin in PCOS. Another important clinical use of metformin is in polycystic ovarian syndrome or PCOS. To understand why it works, we must remember that PCOS is closely linked to insulin resistance. Many women with PCOS have elevated insulin levels, which contribute to hormonal imbalance, increased androgen production, irregular menstrual cycles, and anovulation. Metformin helps by improving insulin sensitivity, making the body's tissues respond more effectively to insulin. As insulin resistance decreases, insulin levels fall, which in turn reduces excess androgen production by the ovaries. This improvement helps restore regular ovulation and promotes better hormonal balance. Clinically, many patients experience more regular menstrual cycles and improved fertility. Key safety considerations. Although metformin is generally very safe, we must always remember that lactic acidosis, though rare, is its most serious adverse effect. Certain clinical conditions increase this risk and should be assessed before prescribing the drug. The first is renal failure. Because metformin is eliminated through the kidneys, reduced clearance can lead to drug accumulation and increase the risk of lactic acidosis. The second condition is severe hypoxia. In conditions such as severe heart failure, shock, or respiratory failure, impaired oxygenation increases lactate production and worsens lactate metabolism. Another important consideration is liver disease. The liver plays an important role in lactate metabolism. When hepatic function is impaired, decreased hepatic lactate clearance can elevate the risk of lactic acidosis. Therefore, before initiating or continuing metformin therapy, always screen for renal failure, severe hypoxia, and liver disease. Summary: metformin at a glance. First, remember the class. Metformin belongs to the Biguanide oral antidiabetic group and remains the most widely used first-line drug for type 2 diabetes mellitus. Its primary action is to reduce hepatic gluconeogenesis. In simple terms, metformin decreases glucose production by the liver, which is the major reason it lowers blood glucose levels. A major key advantage is its low hypoglycemia risk. Unlike insulin or sulfonylureas, metformin does not stimulate insulin secretion, making hypoglycemia uncommon when used alone. Finally, remember the serious risk: lactic acidosis. Although rare, it is the most important adverse effect and is more likely in patients with renal failure, severe hypoxia, or significant liver disease.